of help and education as possible. So the first thing we're going to talk about is actually a USTMA program. It's been one of our big pushes this year. It's been the biggest project we've undertaken so far. We've had great partners with it, and we really appreciate all of the support. We love any feedback from any patients that utilized it. But for now, I'm going to introduce the medical director of the Faster TMA program. You've probably seen him multiple times today, but here he is again, Dr. Aaron Matchin.
So, as everyone knows, here's a little bit of the basics, right? So, this is what is immune thrombocytopenia purpura. This life-threatening, nearly fatal disease caused by a deficiency of AOFAC 13. And now that we know what this is, it's not just do this, something else. Current guidelines recommend is rapid, immediate testing. So, recognize TTP, send a sample out for it. Ideally, send it to a lab that can do it in less than 72 hours. And this is what is considered ideal. And even better, what study has shown is that if you can turn this around in less than 24 hours, it saves time, it saves money, rapidly diagnosing a patient with TTP so they get it, they continue to get the treatment that they need. And if this is someone who doesn't have TTP, well then we can stop the plasma exchange, pull the line, stop the steroids, and give them give them then the appropriate therapy. Next slide, please. So that's great. That's kind of well established. We diagnose them with TTP, we treat them. Then when we send them out the door, as you've heard us, following the AOFAC 13 levels are what we are now doing. It's no longer just following the platelet count, it's following the AOFAC 13 levels. But if you say, well, gee doc, what is the guideline? What is the data? Should we do this weekly, monthly, every 3 months, every 6 months, once a year, never? Never is definitely we don't agree with that, but there is the ICH guidelines don't give us any, they're like, look, there's no data. USTMA, we recommend every 3 months, but we don't know. So what is the problem? Well, on the inpatient side, even my hospital, we were supposed to have it, but COVID fouled up a bunch of stuff. We don't have AOFAC 13 testing. We have to send it to another lab. And on the outpatient side, as everyone has said, and we've heard this, hey, my doc doesn't do it, my insurance company won't pay for it. I can only do it if they think I'm in a relapse, and patients don't have regular access to monitoring. Next slide, please. And so, even though Claire's on the floor, she came up with a lot of this idea, which was, come on, we're there.
Now I'm here. It's
been a real I'm going to let you present now. So, this is like what we have heard from, our members, that this is a problem. Getting this AOFAC 13 testing is a problem. How can I do this when my doc doesn't even believe in it, doesn't want to do it, my insurance company won't pay for it, I have to wait until I'm on death's door before they'll do it. So we had Claire had sent out a survey, and over 100 American patients from America responded in less than 72 hours, like, hey, if we could do this for you, would you do it? If this was free, could you do this? And what would be the benefit for it? And so we came up with a Faster TMA to launch this. This was our hope, that this would be free testing at a lab that could offer us a turnaround time in less than 6 hours upon sample receipt. This would be for both inpatients, so for those hospitals who have to use a lab that only does it once a week, they're contracted to do this lab, or a patient, their insurance company won't pay for it. This program would pay for it. And as part of this would include an option for mobile phlebotomy. And this is for the patients that would say, look, I live 4 hours away from the academic medical center. I don't have a ride. Look, because of my stroke, I can't drive myself. Or every time I see the hospital, I want to vomit and I don't want to go in and get this done, right? So mobile phlebotomy can be arranged. Next slide, please. So for the outpatient testing, all it takes is either the patient or their provider to go to the USTMA website and fill out this form, right? So if a patient wants to do it, You have to put in the name, number of your doc, because they're the ones that are going to have to order it, and that way the result will go back to them. That way we don't have a result just hanging in the ether. And one of two things that can happen. Either they can mail the kit to the patient, that way when they go to their doc and they have a lab draw, they can do it there, or a mobile phlebotomy unit can be sent to the patient's house in order to get the labs drawn there. And obviously, if someone is admitted for an acute flare of TTP, well, that's just done as like any other labs they have done. So we've partnered with Machion Diagnostics. This is a lab that's out in California. They're the ones that will offer 7-day-a-week ADMTS13 testing in less than 6 hours. And we, just so that there's no gaps, this is sent to the ordering physician. Obviously, no offense, I don't want the results if someone else is admitted in Minnesota or in Arizona or in Maine. And it's either on the inpatient side or the outpatient side. Next slide. And so, yeah, so this was, a survey that was sent to all to our participants. If you could get it drawn at home for free, would you? And 90 responded yes within 72 hours. And this is what led to the faster TMA. So Claire, spearheading this, organizing this, we sat down, not even a year ago with Machion Diagnostics and with our sponsors. And we had this sponsored through Sanofi and through Takeda. And we were able to get this rolled out in almost 6 months. And starting in
it was exactly 6 months.
It
was
It's the same, within 6 months, right? And so it rolled out in June, and already we've had 30 outpatients that have used the system predominantly through the mobile phlebotomy unit. And that was just our breakdown. And now we have recently just had 12 hospital systems sign up. So in order to use the faster TMA program. Now, we have the USTMA, we just have very mile-high data. We just know how many are outpatients, are they male, female, chose not to answer, who their doctor was, did they get ADMTS13 testing, and what was it? So we don't know.
That's if the patient consents to let us have de-identified data. If they do not consent for us to get de-identified data, we get a bill and the name of the doctor that ordered it.
And that's it. So, right now, jumping way ahead, yes, there's a lot of things that we would like to do out of this to get data. How many people in the outpatient world, by regular monitoring, did we find ADMTS13 drops? Did it lead to a decrease in relapse rates? What happened when they did? We'd love to know that, but I think what we wanted to first do is roll this out, make sure that there was a resource available for patients where they can get their ADMTS13 levels checked free and as easily as possible, and then we will, down the road, address the research aspect, right, Claire? And to see, hopefully what other benefit aside from just convenience this offers. Right? And so this is still in the very initial stages, in just barely 3 months that this has been open, but we encourage all patients to do this because this is something that we can do testing at home. And while we haven't quite yet done the inpatient, I don't think we have any inpatients.
We have, actually.
Oh, as of when?
Yeah. It was just last week. It was actually a local hospital that didn't have access to Rapid, and they were able to do a diagnostic test that determined the patient's clinical course. So very excited about the program. Again, it's completely free. No insurance information is taken, no credit card at file, anything like that. So, and the reason the comment about the research was made was because there is a lot that the researchers would like to do this, but we have completely rolled it out right now, and we put it just as a patient advocacy organization effort. And so we are hands-off of the data, and we just want to make sure it's something we're able to offer in a resource for patients.
So if it comes around, if you get a nice letter from your friendly neighborhood TTP doc.
It means that I'm dead and in my grave. No. Eventually it would be a great resource for those who consent to it, but for right now, we want to make sure it's just something offered for patients where there's no benefit research-wise for us. Yes, despite there being great protection.
Any questions? All right, thank you.
It's awesome.
A superfluous question.
Go for it.
The way you pronounce when I say add TS13, sound like you said add S13.
Adam TS13.
Okay,
Thank you.
I didn't know if there was a better way to pronounce it. It's just kind of a tongue twister, you know.
Yeah, like Adam, like Adam and
Oh,
Eve.
yeah. I'll put for your slides for you, or
you
you're
found
looking
12 others
wherever you
before.
want.
I wasn't hearing right.
That's fine, all good.
Thank you.
I just need a cup of coffee to dump on there.
Cup of water.
Never gonna let that down, Emma.
No, you're really probably not.
I mean, especially because he was like, all I gotta do is use a finger.
Comes from you all the way from the UK, so we're really excited. AOFAC, right?
Yes.
Okay, cool. Another great advocacy organization focused on TTP. I'm going to let them go through their presentation, but really excited to have them here. Made a tremendous effort to be here, so make sure you thank them.
Thank you, everyone. And good afternoon. I'm Green Clinton from United Kingdom, from King Charles III. Any of us like the royals? Yeah, my name is Folake Afedumo, and I'm the founder of and the chairwoman for the AOFAC Foundation. I'm here with my daughter, Daniela Afedumo, who is one of our trustees and also the chief operating officer for the charity. AOFAC is actually an acronym for my daughter that I lost to TTP in 2012, 3 months to her 19th birthday. A stands for Antonia, O for Onidamola, F for Fulakemi, A for Afedumo, and C for Kusha. We are a patient advocacy group raising awareness of TTP, and our organization has grown to have representation in 3 countries. We are based in the United Kingdom, and we have representatives in the United States, in South Carolina, Virginia, so Washington, D.C., and Atlanta, Georgia. We also have representatives in Nigeria, and we have collaboration with Nigeria Society of Hematologists and Blood Transfusion. The charity is being run by volunteers, who's being paid is being run by volunteers. Next slide, please. Like I said, the organization was formed a year anniversary of Antonia's pass. She fought TTP for 4 years. Every year there's a recurrence. Every year there's a recurrence at a certain time, summertime, when the weather is hot. Perhaps there's something that I don't know. And it's always when she has a period. Perhaps there's something that I don't know. So, the foundation was created in her name to effect change for people like yourself. Because I don't want what happened to Antonia to happen to anyone, to any child, or to a mother, to a sister, to a family. I was listening to people talking outside there earlier on. The scare, the fear of having the condition, of your child having the condition, thinking about it every day, to say, am I going to lose this child? It's something that I play every day to a mother. But I'm going to tell you that lady that was talking earlier on, the system is better. The care is better now. You just have to be conscious of what's happening to your child. Make sure there's anything you notice, seek the consultants, go to your, your, I don't know what you call it here, to your consultant that you are linked with. Don't wait, don't waste time. They'll look after him or her for you. We work in partnership with hospitals, care centers, and healthcare professionals. After Antonia died, we advocated for the way TTP patient access accurate prompt treatment in the UK. We also collaborate with care authorities and pharmaceuticals, such as NHS England, that is the National Health Service England, We take part to effect 9 centers. We have 9 new centers in England. We take active part to make sure that happens for TT patients and survivors. When we started, they only have 1 specialized center. But now, they have 9 centers attached to different hospitals in different regions. We also collaborate with pharmaceutical companies, such as Sanofi. We have their presence there all weekend. We've been to Parliament to lobby for the politician for the white paper for Advocacy to be made available in the UK. It's been available here before UK, so we were part of that as well. We represent patient perspective in the approval of medicine. We work with NICE. NICE is National Institute of Health and Care Excellence. That's a UK national organization that produces useful and usable guidance for healthcare and practitioners, which is an equivalent of FDA. They provide rigorous independent assessment of complex evidence for new technologies. We support TTP patients and survivors and caregivers and family using peer-to-peer, and also we support them directly, get in touch directly one-on-one. We spread awareness of TTP condition through our seminars. We have a lot of seminars virtually when COVID started and in person. We have been to, a lot of GP doesn't know about TTP. So what we do is that during their time to learn, we present to them like in a local group of primary care. Where during their time to learn, they do it monthly. So we present it for them, to let them know about TTP. Even though they think they know, some of them pretend they know. But we let them know more about TTP. And we also do public awareness flyers, and yearly we do our annual 5K walk and high street events, and we have representation in every country that I've mentioned. And our vision is a world where every person affected by TTP receive timely and accurate diagnosis and compassionate care and improve quality of life. We envision a society where TTP, people that live with TTP and the care practitioner know about TTP, that the first point of contact in any hospital or organization know about TTP. I will now hand you over to my daughter, who will actually go on a topic, which is improving emergency care. Thank you for having us.
Hi everyone, forgive me if I'm a little bit nervous. We were so excited to be here and meet all of you and hear your stories. And when Claire let us know that we've got about 10-15 minutes to speak to you, we debated what we're going to speak about, what we needed to hear about. We didn't want to repeat information that you might have already heard or repeat things that you already know, because you're the experts, you're people living with the condition. You've dedicated your lives to researching the condition. So we actually put out a survey and asked all the patients in our network what we should speak about. And one thing that came quite a lot was emergency care. So when you're in the emergency department with TTP, we thought this was a really important subject to bring some more attention to. So if we go to the next slide. We have a scenario that we actually found ourselves in with Antonia. And it's something that I've heard mentioned quite a few times today, which is probably the worst case scenario, but especially in remission and relapse. So imagine you find yourself in the emergency room, you think you've relapsed and you're having an urgent crisis, and for whatever reason your specialist, your consultant isn't available, and the doctor on call has no idea what TTP is. It's a scary situation, I'm sure, and in remission, you're not tested as often. You don't have to be. It's 3 months or 6 months, and unfortunately there could be an occasion where you find yourself needing to go to the ED. So what do you do? I think we all know that speed is the most important thing when it comes to treatment. In the diagnosis, you already know you have the condition, but also in treatment. So if you go to the next slide, you'll see that we found studies that say that the recommended time for treatment is 4 to 8 hours in getting a line into you. And treatment is so fast, as we all know. Treatment needs to be so fast, as we all know, because we have blood clots that can cause damage to the organs, and that can lead to terrible consequences such as a stroke or issues with heart, kidneys, and a whole host of other conditions. But when we have treatment, survival can be as high as 90% or more, but without it, it can be as low as 10 or 20%. So we were thinking about why these delays can occur, and there are loads of factors. For an emergency room doctor, their specialism is general. It's making sure that they can get to as many people as possible, and they're not necessarily thinking of TMAs and rare conditions, and that can be because of a lack of awareness and starting this treatment, and that can lead to a limited sense of urgency that can cause issues. When Night and Tony passed away, we were in the emergency room for about 14 hours before we were able to get someone to see to her and administer treatment, and that's something that we don't want to happen to anybody. It should be a rarity in a story. It shouldn't be a common occurrence for any of you or your loved ones. Delay can be caused because of unfamiliarity with you as a patient or your loved one and their history. And also, as was mentioned earlier, there could be a limited access to care or that specialist treatment that is needed. So these are really big problems that I'm throwing at you, and it's kind of a bummer, I'm sorry. But what do you do in that situation? And what I want to use my 15 minutes to do is to urge you to advocate for yourself if you're a patient, to be fighting for yourself, to let that person know that's treating you what TTP is, to educate them, because you're an expert first and foremost to anybody else in that room. Unfortunately, some of the time, if you're unable to advocate for yourself, then caregivers, your parents, your loved ones, your husband, your wife, your bestie, anyone, educating them so they can educate the doctor on your behalf to make sure you're getting the treatment that you need, that they're not looking at the wrong things and looking at platelet counts, or maybe adding 13, but looking at the things that they need to be aware of. And if you're a consultant or a doctor advocating for your patient, perhaps calling into the emergency department if your patient knows, if you know they're there. And if that's not available, perhaps finding an advocate in the room, demanding to speak to someone, making sure you're heard, making sure that you can't be ignored, to make sure you're getting treatment as quickly as possible. Because no one can tell you that it's not an emergency, you know what's going on in your body and you know what needs to happen next. So that's things we can do for now, but in future, we want to change this. We want this to be something that isn't a common story, that you don't have another person like me or my mum in the room saying this is what's happened to us, we want to change things. And we think that needs to be an education and awareness in paramedics and first responders, people who you might call that will come to pick you up to make sure that they're getting you to the hospital as quickly as possible, in general practitioners, in doctors, nurses, people who might not have that specialism, making sure that they know about TMAs and TTP and the other conditions so that you're confident that you're going to get that treatment and you're going to be okay. And also regulators to make sure that there is a legal practice of what needs to happen next, to making sure that you survive, that you go on fighting another day. And that is my 15 minutes. Nervous and eager to sit down. Does anyone have any questions?
So you're saying that y'all went to the hospital and that you knew your sister had TTP?
Yeah, she had been diagnosed. So Antonia consistently had low levels of Adam's 13, so she would relapse quite frequently, like my mum was saying. So we saw the signs, we knew the drill, we knew that we needed to get to the hospital and get treatment as soon as possible. But we lived just outside of London, so that was at the time the only care facility that was able to treat her, so we needed to get there as soon as possible and just get some help.
So what about Dr. Scully worried about thinking?
And what happened on the day, normally they gave a number to us. that to access a specialist nurse.
Uh-huh.
The specialist nurse was on holiday.
Okay.
So she gave the number to someone else.
Oh.
So when we call to say Antonia is not well, we need to be there now. Normally, they take us straight to here. Everything is ready for her. The machine, everything is ready. But because the phone was in wrong hand, she was saying go to the nearest A&E. We were in an ambulance. We were already going to London. To London. She was saying go back to another hospital. We were telling her, no, we can't. This is the way to do it. Anyway, the ambulance refused because they were talking and fighting each other. The ambulance refused to go back. We went to London, but they took us to A&E. And then we were there. And then we were there. I was telling them, check the blood, the platelets, check the hemoglobin. That's all you need to know that TTP is back. They didn't listen. So they delayed and delayed and delayed. So by the time they start her first machine procedure, she passed away an hour later.
Yeah. We don't want that to be your story.
No. No. Any other question?
So we'll pass over to the lovely people from the...
And it was on a weekend. And when you have Friday crisis, please be sure to say, please get me my consultant. Because some hospital, okay.
It's a very good point. Another great representative, we have another great organization, definitely want to highlight, is the Wynn Foundation, another great ITP representation here, and our last representative from the AHS Alliance. But for now, Wynn, I'll let you do your spiel, but I just want to talk about what a great patient advocacy organization you guys really are.
Well, go ahead.
Yeah, really ramped it up, and it's nice to have a good partner in the U.S. too, as well.
I don't mind the
Yeah.
praise. It helps. All right, you can all applaud when you're ready. I'm James Wynn. I'm with the Wynn Foundation, and we're here today. We're going to talk a little bit about some of the initiatives that we have, and to kind of piggyback on what AOFAC said, how to advocate for yourselves. Right? So it's a big part of what we do. We were founded 2012 after my sister passed away from TTP. My sister's name is Rishima. That's why we call the Wynn Foundation. She had no prior interactions. I'm sorry, it get a little hard sometimes. But she had no prior diagnosis of TTP, and she passed away within 12 hours of going to the hospital. The only way we knew that it was TTP was because the petechiae started showing up on her skin. But by the time that showed up, and they tested, of course, the blood clots had started to go to her heart, so she couldn't get the plasma exchange because it was dangerous at that point. And she ultimately passed away from cardiac arrest. So, in her honor, in her memory, my mom and I started the Wynn Foundation because Mom didn't want to receive gifts or flowers or anything like that. She just wanted people to give to the TTP Foundation. Well, we couldn't find one. So she said, well, since we can't find one, you'll start one, and that'll be your job. So it's been my job. But, so this is why we began, and why we continue has to do with this slide. We have folks who are now called TTP Warriors. So our mission is to provide education and promote awareness about TTP and help to reduce the mortality rate, enhance the quality of life for people who are living with the disorder. You gotta be a little quicker than that.
Sorry, I don't get paid.
Oh yeah, I didn't mention, we're all volunteer work. Sometimes you get what you pay for. All right, so this is what we do, and we do quite a few things. Really breaking down our organization into kind of the core values that my mom's set up for us, and my mom, you guys should know, passed away just about 2 years ago from COVID. So really spiritual person. Our slogan, dear friend, above all things, we would want for you to prosper and be in good health. And that's a model that we follow, and have to serve mind, body, and spirit. Mom always said that. And we do that with hope, support, and advocacy. So as we go through these buckets, you'll see they fall in those categories of hope, support, and advocacy. We provide education days. Education day is really important because, as folks have said between us, the lack of education leads to slower diagnosis, leads to misdiagnosis. So we've been partnering with the University of Pennsylvania for the last 5 or 6 years, providing a day-long education day in the morning or first half of the day. It's patient-centered. So we have an expert come in, talk to the patients about different topics that are going on in TTP world. That same discussion happens in the afternoon for medical professionals. It's not only medical professionals, but also students who are still in medical school. So they're kind of coming out of school with it fresh on their mind. Now, this year we've expanded that. We're doing that with Duke University as well. Or the University of Duke. Is that what
Duke University?
You better get that right around here.
Yeah, I better get it right.
Where you at? Where you at?
And you guys just beat Clemson, right? So we're doing that with Duke University this year as well, November the 29th. We're also looking to expand that. Hopefully next year we can get up to about, I'll say it anyway, I know you're gonna. But we're going to try to get to 24 different locations around the U.S., providing education so that there are more patients who understand better what's going on with them and how to advocate for themselves, but probably just as important, or more importantly, more medical professionals who understand the disorder and are able to help diagnose quickly and lower mortality rates. And that's what we want to really do. So we have blood drives, and we always try to encourage people to give plasma as well. We do those about 5 times a year. This year, something that's really big, we've been awarded an opportunity to host an externally led patient-focused drug development program. I know it's a lot of words. It's an ELPFDD. I know that means nothing to you. But it's a big deal because what it means is the FDA put out an RFP and said, hey, we want to host a meeting about ITTP and allow patients to come and tell us exactly what's going on with them, tell us how they want to be treated, tell us how the onset of the disorder, and we'll package all of that together in a report, give it to the FDA. The FDA will use that to help influence treatments going forward. And when I say influence, they're going to be talking to manufacturers, pharma companies, et cetera, and also the U.S. government, of course. CDC and NIH will all be involved in getting that report and making sure that the treatments are following the specifications set forth by the patient voices. So we're really excited about that. We're going to host that meeting January 26, 2024. I feel like I'm going too slow. We're good? All right. Fundraising events, we have our Journey to Healing bowling event and Gift of Life luncheon. That's, my sister loved the bowl. So I should probably tell you more about what's going on here. My sister's favorite color was green. You saw the olive branches at the beginning. Mom always thought olive branch was important because it means peace. And if you extend an olive branch, you help strengthen relationships and things like that. So all of these things that we do are significant in one way or another. And it all ties back to my sister's memory. Next. Some of the programs we have, we're really excited. I'm saying this a lot, right? Really excited because this month, not this month, because we're still in September, right?
No, it's
Oh, it's October 1st. Bang. You see what happens when we got volunteers?
Tomorrow.
In October the 15th, we're going to launch an emergency support program. The emergency support program will provide financial support to people who are diagnosed with TTP and have a financial hardship. It's really important to us because so many times, and then we'll just go to the next one, in our support groups, people would indicate that they were struggling financially, that they didn't know how to get tied to mainstream resources, whether they needed Social Security or they needed to sign up for food stamps, things like that. They didn't understand those processes. So this program will allow us to help them to do that. But probably the most important part, if you have all these other financial burdens coming on because of your diagnosis, it's kind of hard to focus on getting better if you have to focus on, getting well financially as well. So that's our way to help that. TTP support groups, volunteers. we host them monthly. What's unique about our TTP support group is they're patient-led. And by that, what I mean is patients give us, at the beginning of the year, ideas about what topics they want to cover. We go out, we try to get experts to cover those topics every other month. So every other month, patients talk, right? And then they talk according to whatever topics they want to. Then that following month, we have experts come in. So people come in and talk about things that most folks might not think about. People don't realize that TTP affects you cognitively as well. There's an issue with PTSD. So we've had an expert come in and talk about PTSD related to emergency room stays. We've had people come in and talk about mindfulness, how to be centered, how to cope with different things, which I know you had here today. So it's a very, very robust type of support group. If you're not part of it, join us. All right, so our accomplishments since 2012, of course, we've raised funds in order to support the organization, and that leads us to our next thing, which we give grants to University of Pennsylvania, University of Alabama, and volunteers. The blood drives that we do every year, we are, because when people give whole blood, a lot of people don't know this, you have the opportunity to save up to 3 lives. The blood, right? The plasma, and the platelets. And what happens is they separate those out and give it to the folks who need it as they need it. So because of that, we're over 1,000 lives saved since we started. And then we provide patient support, not just with the support groups, not just with now the emergency support program, but also one-on-one consultation, just being there for people, sending fruit baskets, doing things like that, that just let people know that someone cares and we're all connected. They're not alone. That's the biggest thing. Thank you. How about a hand for my lovely volunteers? Any questions?
Okay, so this is, you're wanting volunteers to like open in different states? Is that where you're at, saying? Like.
I didn't say that, but
Yeah,
that.
that's
24 different locations for education and engagement.
Yeah, that's.
Oh, I'm sorry. But let's talk. So what?
You did see how he treats his volunteers.
And she's married to him,
So the 24 different locations that we're looking for are hospitals or academic facilities where we can host education.
Oh, I see, okay.
But that is a great idea.
But we do have connections to
Yes.
our local San Antonio healthcare system,
Great.
that kind of stuff. With
Yeah.
physicians there.
Yeah,
So
so
we're
then,
trying to connect with USTMA and you would be a perfect match for us.
Well, just so we're saying, you know, he's a survivor, so.
he's a warrior.
He's a warrior. So it would be informational to say, okay, this can't happen, but look right here, look what we did, you know?
Yes.
And look at all the other people that we helped, and it is out there, so that would be interesting to work with someone like that. You know, you can kind of guide to help educate, you know?
Sure, absolutely.
Your patient groups are your warriors. Your patient groups are your warriors.
Yes.
You do that Zoom or through?
Yep, we do that on Zoom the third Tuesday of every month at 7 p.m. And you can go on our website. We've recently revamped our website in an effort to make it more educational, user-friendly. See, sometimes volunteers work out. More
Is anybody going back to Maryland?
I knew you said one too many times.
So we wanted to make it more user-friendly, have more resources that people can easily get to. In our support groups, people express the types of resources that we need. So we want our website to reflect that, and it does now, as much as we can, and we're always looking for new stuff to put up. But with regard to the support groups, you can go up and sign up for the whole year.
And just to kind of, the TTP Warrior, we often had an option that says, are you a TTP patient? And then we changed it to, are you a TTP survivor? And it was our support group members who said, we want to be called warriors. And I said, okay, you guys are now warriors.
And now we have a commercial too.
Well, I was watching something like a satellite to kind of, you know, to spread awareness. That's what
Yeah.
I'm
I know.
We are on the same page.
Yeah, absolutely.
Yeah.
Thank you.
Thank you.
So, yeah, great job, yeah.